Thank you, Ekta, and good morning to all. I am Dr. Sushmita, and we'd like to start with the first talk. We have a very young and dynamic gun presenting the first talk. He is Dr. Sushank Bhalerao, who is trained at Government Medical College, Aurangabad, followed by his post-graduation at RIO Allahabad, and he has completed his fellowship training in cornea and anterior segment at LVPI and is currently a faculty at the KBC campus, Vijayawada. So first talk, Dr. Sushank is going to speak on intracameral foreign body removal, tips in removal. Over to you, Dr. Bhalera.
Okay. Is my screen visible?
Yes, absolutely.
Okay. I'll be speaking on tips in removal of intracameral foreign body. And initially, I'll speak briefly on introduction and approach towards the case. Then I'll discuss about challenges for surgeon, methods of intracameral foreign body removal, precautions during surgery, and then 2 case scenarios along with their videos. Penetrating ocular injury may be associated with presence of IOFB, and 15% of all IOFBs are anterior chamber angle foreign bodies. Missed IOFB can lead to atypical clinical features, delay in diagnosis, and inappropriate management. If not removed in time, it may masquerade as a idiopathic chronic iridocyclitis. How to approach towards a case? Proper history should be taken, including mechanism and duration of injury. Composition of object should always be inquired to the patient. It can be metallic or non-metallic. Slit lamp examination in extremes of gazes should be done to locate the foreign body. Cedars test should be performed to check any leak. Gonioscopy should be done whenever not contraindicated to locate the foreign body, and fundus examination and gentle B scan for any posterior segment foreign bodies. Although UBM helps, ASOCT is also helpful in diagnosing and managing the intracameral foreign bodies. Now coming to challenges for surgeon, there might be decreased visibility due to severe corneal edema, and scraping of corneal epithelium may help. Lots of KPs with pigmentation can produce a greater challenge while removal of the anterior chamber foreign body. And in that cases, we should decrease the inflammation with the help of steroids or wait for surgery, wait for some time before going ahead with the surgery. Like this patient operated for a traumatic cataract, presented 1 week post-op with a limbus to limbus corneal edema, and foreign body was located on UBM after reducing the gain. Although because of poor view, foreign body was removed by endoscopic approach, but the patient went into the endothelial failure, for which DSEC was done in later visit. Then continuous bleeding can occur in cases of iris injury after removal of the foreign body. In that cases, viscoelastic will help. Just take care not to wash anterior chamber with the Simcoe or Hydro when foreign body is inside. Otherwise, it may get lost. You have to keep a watch on foreign body. And then poor visualization, lens injury, bleeding and pushing IOFB against the posterior chamber or ciliary sulcus may happen. It can be removed with the endoscopy assisted, novel approach or conventional approach. Endoscope can be entered through a clear limbal corneal incision, and foreign body located into the anterior chamber, and it is removed with the help of forceps, like it was done in this case report, which was published by our institute. Huang et al. Removed foreign body with the help of prism contact lens and 23 gauge foreign body forceps. And conventional approach we'll discuss in our videos. Precautions during surgery: side port should not be long, it should be shorter one to avoid stucking of foreign body beneath that. Then position should be around 2-3 clock hours away from the location of foreign body. Protection of anterior border, anterior and posterior boundaries are must. Viscoelastic will help in protecting endothelium, and viscoelastic along with meiosis will help to protect the lens. Separation of foreign body from surrounding tissue should be performed gently, and it should be started from back of anterior chamber foreign body to the front to prevent injury to the angle. Removal of foreign body with the help of microforceps should be done without damaging the endothelium, and alignment of the microforceps should be perpendicular to the foreign body while removing and bringing it towards the side port, and it should be along the long axis of foreign body while removing it outside the side port or incision. Check for any residual foreign body, and visco wash and proper hydration of side port should only be done only after complete removal of foreign body. Otherwise, residuals may be lost into the deeper layers. And then intracameral foreign body can be given. Like Ishii et al. Use intraocular lens injector for removing the foreign body to protect endothelium as well as the lens. But this technique can't be used for bent foreign bodies. So this was a case presented to us with a stick injury, and foreign body was located into the angle of anterior chamber with the help of UBM. And this is the video of the same case. First foreign body is located, then side port is made around 3 clock hours away from the main foreign body, then pylo, then visco, and then foreign body is separated from the surrounding structures with the help of the repositor, and foreign body moved to the newer side port or newer incision which was extended. Chamber should always be deep, and then foreign body is removed with the help of micro forceps. After this also, then we have to check for any residual foreign body. Like during hydration, we found one foreign body was there into the anterior chamber, but not into the main site. Then it was separated, and then again visco was injected. After that, foreign body was moved towards the under surface of one of the side port, which was brought forward with the help of repositor, and then it was taken into the hydrocannula by suction. Then visco wash was done, and chamber was hydrated. Post-op day 1, it was improved to 2020, and patient was given empirical therapy. This is second case presented to us with an inferior anterior chamber endo exudate at 5 to 6 o'clock hour. And ASOCT detected one foreign body with hyperreflectivity, which was surrounded by moderate hyperreflectivity, shown with the red arrow suggestive of exudate surrounding it. So this is the video for the same. Then side port was made. After that, pilocarpine was injected, then visco was injected. Then after separation of endo exudate, the foreign body was searched. It was separated from the surrounding structures with the help of the repositor. No sharp instrument like dialer should be used, otherwise it can damage other intraocular structures. Then it was seen that whether any residual or any piece was left behind into the exudate. And then with the help of micro forceps, although it was removed, like holding should be perpendicular while bringing it towards the side port, and it should be along the axis while removal. Extension is a surgeon's choice or depend on the type of foreign body which we are removing. Like in this case, it was like our iris hook, so I did not extended the side port, and it was removed. Otherwise, clear corneal incision can also be used to avoid the damage to endothelium. Then endo exudate was removed and sent to the microbiology, and then we checked for any residual foreign body. And then wound visco wash was done, and wound was hydrated. It was improved to 2060 on day 1, and then up to 2060. After 4 days, we did ASOCT, which showed no retained scraps of IOFB, and mild AC inflammation was seen into it. So we published this case into the IJO case reports. So finally, take home message is IOFB should never be missed, and it can lead to complications, and proper technique should be followed and appropriate care should be taken while intracameral foreign body removal. Thank you.
Thank you very much, Sushank. That was a very excellent talk about something which is very often missed and lead to a lot of complications. So as discussed, we'll take questions at the end of the session. So I next invite for the talk, Dr. Bhaskar Choudhary. We are very privileged to have him today. He's a senior cornea cataract specialist, and he is the director of Tamanash Eye Foundation in Kolkata, with more than 20 years of experience in cornea and ocular surface work. And he is also the one who has given us the MCerter, a very easy to use device for amniotic membrane grafting in severe cases. So over to you, Dr. Choudhary, for your talk on amniotic membrane grafting in 2 minutes, simplifying the management of acute ocular surface burns and SGS.
Thank you, Sushmita. I hope my slides are visible.
Yes.
Okay. We all, as ophthalmologists, we have been long associated with the human amniotic membrane transplantation, and we know that we are interested only in the amniotic membrane, and particularly in the stroma of the amniotic membrane, not much in the cells of the amniotic membrane. So wide use of amniotic membrane in ocular surface reconstruction with slit and cleft, and as a conjunctival substitute for reconstruction of conjunctival defects following removal of pterygia. The main uses of ham, where it really makes a difference in the patient's care, are acute chemical burns of the ocular surface and acute Stevens-Johnson syndrome. So we know that amniotic membrane transplantation is particularly useful in grade 4, 5, and 6 of chemical burns of according to Dua's classification. And in acute SJS, we know that there is a war on the ocular surface. So everything is damaged: epithelium, goblet cells, stem cells. And as per the category, the grading of Darren Gregory, severe and extremely severe cases benefit from amniotic membrane transplantation if it is done within 48 hours. And these gradations are more than 1/3 of the lid margin taking stain or any epithelial defect on the cornea, and a stain positive greater than 1 centimeter in the palpebral or bulbar conjunctiva. So the conventional way of doing an amniotic membrane transplantation is, of course, overlaying the amniotic membrane on the eye and then tucking it with a blunt instrument and suturing it to the lids using bolsters, and then finally put in a conformer. But this job done at the ICU, often with topical anesthesia or without any anesthesia, and it is extremely painful for both the patient and the surgeon. There are certain devices in the market, like the Procera is widely used. It is manufactured and marketed by Dr. Shepherd Singh. But the problem with Procera is that it covers only a small area of the eye, only up to 2 millimeters beyond the limbus. So we felt that there was an unmet need, and for that we decided to go in for a device which could be readily assembled in the on the bedside. So for that we went through certain design evolutions and finally came up with a 2-ring device, a bottom part and a top part, whose assembly and use I will be showing today. So this is the dimensions of the device. It is 24 mm wide and 20 mm in height, elliptical, and there is a notch on the bottom ring. So we have only one size, and whatever experience we had till now, including pediatric cases, we find that this size fits all. So we have not really had the case for developing another size. Now, first I will show you on the left of your screen the dry assembly of the device to understand what actually happens. So you can see the notch was shown by the forceps. Now the top ring comes and it snap fits into the bottom ring. So after this, you will see how to attach an amniotic membrane, and you can see that this device is fairly compressible. This is why it can fit in almost cornices of almost any size. So you tuck the bottom ring below the amniotic membrane, and it has to be kept wet all the time. And you bring the top ring and sandwich the amniotic membrane in between. This is an alternative technique in which if you do not want raw edges of your ring to be exposed, then you can put the ring on top of the membrane and gather all the amniotic membrane inside and then put the top ring. And then this entire ensemble, it can be inserted like a contact lens. And this assembly can be done anywhere. It can be done at the bedside or in the eye bag. So here is a small video of its use, courtesy Dr. Rishi. And you can see that the surgeon is holding it in his hands and simply moving it in and placing it in the fornix. And when he'll remove the speculum, lid retractors, there is no problem in lid closure. It can close easily. So this is another use in a pediatric case of SJS by Dr. Bhupesh. And you can see that it is being assembled on the gloved hand of the surgeon. Although ideally this should be done under microscope on the inside the OT, and then you can carry it in the carrier for amniotic membrane and take it. Now you can see what Dr. Bhupesh is doing is he is taking the extra part of the amniotic membrane beyond the ring and draping it over the lids. So if you want to give lid cover, this is also available. So this is a case of recurrent pterygium, had 2 recurrences, and there was a dense adhesion in the medial, near the medial canthus, with both lids, dense symlifera, so much so that the patient had a diplopia in primary position. Now, after doing a normal conjunctival autograft and releasing the symliferon, we did not go for any cover of the raw lid surface. Instead, we put in the amniotic membrane inserter. So this can be easily placed with the forceps, and it covers the lid very snugly and prevents symlifera. So these are the results. You can see that the amniotic membrane, this is the first post-op-day picture. You can see it sits very nicely. There are no problems of lid closure. And you can see how the patient improves from, and the patient is completely devoid of diplopia and recurrence now. This was our first case, a 14-year girl with acute SJS, and we did an amniotic membrane grafting in the ICU using the inserter. And the very first post-op day, you can see that the symlifera do not develop. And this is the 14-day post-op. You can see that even with the amniotic membrane in the eye, you can see the cornea and anterior segment details pretty clearly. This is another case of inserted in a chemical injury. And this is another use of amniotic membrane inserted in a case of Chuna injury. And these are the results. This has been used in large epithelial defect, corneal epithelial defect following chemical injury. So the advantages, to sum up, is the elliptical design which conforms with the shape of the fornix. It is deformable yet with good memory, and it is not brittle. We have tested it in minus 80 degree storage also. It does not become brittle. You can mount an extra AM. We have used up to 3 layers of amniotic membrane, and you can apply glue on the undersurface, although it is not needed. So is the job done? Well, I think that we need to educate critical care specialists and dermatologists and also ophthalmologists about the availability of the procedure, which will really make a difference to the lives of the acute SJS and chemical injury patients. Thank you.
Thank you, Dr. Choudhary, for an excellent talk and a very useful tips in managing acute burns. Our next speaker is Dr. Sushmita Shah, an excellent surgeon and a very caring physician. It's a pleasure to have you on this panel. She is going to speak now on the tenoplasty in severe chemical injuries. So over to you, Dr. Sushmita.
Yeah, thank you very much, Arvind, for that kind introduction. And it's a pleasure being a part of this session. So I shall start with this case of a young male industrial worker who was referred to us. This was about a decade ago. And the patient had unfortunately got exposed to molten aluminum while at work. And he had undergone an amniotic membrane grafting after about 6 weeks of the episode by the referring ophthalmologist. And since that amniotic membrane grafting did not work, so he was referred to us 3 weeks after the amniotic membrane grafting. Had a visual, still had a hand movement vision, and you can see the clinical picture, diffuse corneal welt with a large central perforation. So we did a tectonic keratoplasty with a central tarsorrhaphy. Surgery was uneventful. However, hypotony persisted, and this eye became prethysical, and eventually we lost the eye. So that brings us to the question that I'm going to address in this talk. What do you do when amniotic membrane alone, transplantation alone does not work? So coming to tenonplasty in severe chemical injuries, this technique was first described in a Lancet paper in 1995 by Dr. Kakelhorn from Germany. What this technique they proposed was that if you mobilize the tenon capsule, which has a rich vascular supply from the deep orbital tissue in eyes with schirocorneal ulceration, and secure them with 9-0 vicryl sutures, you can take care of the conjunctival and the scleral ischemia and necrosis that follows following severe ocular burn. So in their series of 64 eyes of 50 patients, they following tenonplasty, they noted close to 80% conjunctival epithelialization in 80% cases in 3 weeks, and in all 100% cases over 5 weeks. The fornices were maintained in 78%, and symblepharon was noted in only 22% of the eyes. This was another subsequent paper from that group, and it's a very simple diagram showing how they mobilized the tenon from the periphery, from around the extraocular muscles, and secured it perilimbally. You need to secure it about 1 to 2 millimeter from the limbus, and that is how it helps in maintaining limbal and as well as the avoiding scleral ischemia. Now, why and how? Why and when? So chemical, because of chemicals, you can get chemical induced conjunctival and episcleral ischemia that leads to severe scleral ischemia, and there could be necrosis of the conjunctival tissue as well as the episcleral tissue, leading to inflammation. And the late manifestation of this is scleral ulceration with threat to the surviving limbal epithelial cells. There is also ciliary body ischemia and hypotony, and then that is the end of the road for the eye. We lose the eye once the ciliary ischemia and hypotony sets in. So these are 4 images from this published paper from Shankar Netralaya by Dr. Iyer's group. As you can see, the leftmost picture, there is a small area of scleral ischemia, which is it is highlighted with the help of a yellow marking. The remaining 3 pages on to the right show much more higher degree of scleral ischemia. So what the authors describe is how do we approach these cases? Well, the first one, which is very mild scleral ischemia, we could always observe, maybe do amniotic membrane grafting and also do manage conservatively. But the other 3 with severe scleral ischemia, that definitely need tenonplasty at the earliest. So just to compare between amniotic membrane grafting and tenonplasty, what works where? Amniotic membrane grafting, it promotes epithelial differentiation and promotes epithelial healing, had a little bit of corneal anti-neovascularization effect, and most importantly, it is anti-inflammatory and anti-fibrotic, and it is advisable in grade 2 to grade 3 burns as far as the Roper Hole classification is concerned, and also for the higher level of burns in the Dua classification. Tenonplasty works very differently. It brings in vascularization to an ischemic sclera. It helps in epithelialization of the conjunctival epithelium. It is also helps in epithelial healing in eyes with failed single or multiple amniotic membrane grafting, and it is indicated in grade 4 burns of the Roper Hole classification or the grade 5 and grade 6 burn of the Dua classification, and you often have to combine it with the amniotic membrane grafting. And sometimes in cases of large scleral ulcers where the amniotic membrane grafting may not be alone, and tenonplasty and amniotic membrane grafting may not suffice, you may also need to put a mucous membrane graft. Now, coming to a few cases, this was one young male, again, a bilateral acid injury following a blast at the workplace, and the referring ophthalmologist had done an amniotic membrane grafting soon after, but the scleral ischemia persisted, so this patient was referred to us. He was grade 5 Dua classification when we saw him about 10 days later, so we planned a bilateral tenonplasty along with the amniotic membrane grafting the same day. A short video. As you can see, the eye is very, very ischemic. And as we cut, when we excise the the damaged tissue, you can see that there is absolutely no bleeding happening, which essentially indicates that this is all dead and necrotic tissue. So when we do surface reconstruction in such cases, it is very important that we excise all the dead tissue. Leaving those behind on the surface really does not serve any purpose. So you need to excise till you reach a point where it starts bleeding. Now we have, as you can see here, we have hooked the inferior rectus muscle and we're using the 4-0 silk. You could also use the eyed muscle hook. The necrotic tissue is being excised. I'm sorry about the video, is running little in a sluggish way. Some bleeders need to be cauterized if required, but please don't do over cauterization. Now, as you can see here, we are separating the tenon from the underlying, from the overlying conjunctiva. And this tenon is then brought and secured near the limbus, around maybe just a millimeter away from the limbus, using 70 Vicryl. Then we put a amniotic membrane to drape the entire corneal, entire ocular surface. We secure the amniotic membrane all along the limbus using circumferential sutures using 10O nylon. The peripheral edges of the amniotic membrane is secured to the surrounding conjunctiva using 8O Vicryl. And this is how, these are the immediate post-operative photographs. About 2 months, as you can see, the surface is vascularized and there is no symblepharon anywhere. And this is the follow-up of the same patient close to 2 years later. He had 612 vision in the right eye with partial LSCD. The left eye vision was 636. Here also there is some partial LSCD with some retained amniotic membrane, and also had some anterior subcapsular cataract. This was another gentleman, 36-year-old, who got exposed to acetic acid while at work. The right eye, the exposure was much more than what was there in the left eye, and had a finger counting vision in the right eye. And following fluorescence staining, we could see that the right eye, it was grade 5 as per the Dua classification, while the left eye was better off, it was grade 2. So left eye we continued with the conservative management, and right eye we did the tenonplasty along with AMG. Here I would like to reiterate the importance of staining and looking at the total ocular surface while you're evaluating the patient in the clinic. Unless we do a careful examination, you will not be able to get a proper grading of the injury, and that is extremely important to determine the management plan. So these are the two eyes. The right eye, you can see we have been able to save the ocular surface, so there is LSCD. Corneas are good. The left eye did very well. The right eye, we advised him to undergo a slat, but patient was subsequently lost to follow-up. This is another young male. As you can see, an extensive burn involving his entire face and upper body, and also both eyes. So he got exposed to DMAPA, which is an alkali, and the amniotic membrane membrane grafting was done by the referent ophthalmologist the very next day. And in spite of that, when he was referred to us 1 week after the injury, he had just PLPR vision and grade 6 injury in both eyes. Amniotic membrane was dissolving. The right eye, already hypotony has set in. So we did a bilateral tenonplasty with amniotic membrane grafting as well as a lateral tarsorrhaphy. Unfortunately, we could not salvage the right eye and it became pre-thicical. We could somehow salvage the left eye, which PLPR vision, fornices were good, but there was 360 degrees LSCD. And after 1 year, and type 1 posterior keratoprosthesis with lateral tarsorrhaphy. So this is how he looks. He has a vision of 6/60 N6. So this is what has been very specifically, prepared by Dr. Geeta Iyer from Shankar Netralaya, that if you are able to save the globe at the time of the acute injury using procedures like tenonplasty, you can always rehabilitate the eye later on with a Boston keratoprosthesis. But managing these eyes at the time of the acute injury is really critical. So to summarize, detailed clinical evaluation is mandatory to delineate areas of epithelial defect and ischemia following chemical injury. Tenonplasty may be effective in salvaging eyes with severe chemical injury by increasing blood supply to the ischemic tissues, and it acts as a globe slaving procedure for subsequent visual rehabilitation. Thank you very much.
To Dr. Shah. Our next speaker is Dr. Sheetal. Dr. Sheetal is a dedicated and very motivated anterior segment surgeon. She has a passion in corneal transplantation and anterior segment surgery and refractive surgery. Today she will be sharing her experience on customized keratoprosthesis. Over to you, Dr. Sheetal Mahua.
Yeah. Am I audible?
You are audible and your slides are visible.
Okay. Thank you so much, Dr. Arvind. And at the outset, I would like to thank Dr. Somshila and AIOC for giving me this chance. So today I'm going to talk about a case which of a keratoprosthesis, which I have done a little differently. As we all know that when there is a bilateral limbal stem cell deficiency, the PKP results are very, very discouraging, and rather they do not work at all. So in such scenario, we only have two options. Either you do alloslet or you do keratoprosthesis. Now both the procedures have its own pluses and minuses, and both the procedures do require a lot of dedication and follow-ups. So this was a patient of mine only where I had done a keratoprosthesis. As we all know that the BCL, this was a typical keratoprosthesis, Boston keratoprosthesis. And as we all know that BCL is very, very important in putting over the keratoprosthesis so that we can prevent a desiccation related complications like epithelial breakdown, stromal melt or necrosis. This is a patient where the BCL is sitting very well, and now we have a follow-up of 5 years for this particular patient. Now, this is my second case where where you can see that there's dense symblepharon and a lot of fibrosis, the granuloma formation over the surface. So what I did in this case was I had removed excised the panels, released the symblepharon and did the keratoprosthesis, and I actually put the BCL also, but I realized that BCL was not sitting well because of the symblepharon, as well as there were a lot of air bubble formation which was happening. So I thought that let me remove the BCL and put the amniotic membrane graft, and I did the medial and lateral tarsorrhaphy. But unfortunately, even though I thought that it will prevent desiccation related complications, it did not, and it eventually went into stromal necrosis. Later on, this patient had infection, and I had to remove it, explant it, and do the therapeutic keratoplasty. So as I said that these cases have very, very difficult difficult journey per se. So this is another case where it was post chemical injury. Patient amniotic membrane graft was done elsewhere, and this patient went through a lot of eventful course. We did the tarsorrhaphy, but patient still did end up with a lot of granuloma formation, fibrosis, symblepharon. At some point in time, I did the slet. I did the slet from the cadaveric graft, but it really did not help, and eventually this patient landed up like this. So this is a short video of my case where at this point in time, I thought that let me do the keratoprosthesis under the panels because I had learned from my last case, and I released the inferior symblepharon, and then we started dissecting it from the superior edge. Now it is very, very important out here to take the panels excise the panels in one single sheet. If you get the breakdowns or if you get the buttonholes, then it would be very, very difficult later on for the follow-up or whatever aim you want to achieve, it may not be able to achieve it. So after excising the whole panels over the surface, you need to release everything, and I tried to see whether it covers the ocular surface. At this point in time, I actually could put the speculum, and I realized that it was still not covering it very well. So I did a little bit of underneath fibrosis excision, and later on then I got a nice cover of the panels over the surface. We did the 7.5 millimeter trephination of the host, and at this point in time I do not do the complete trephination, and we start assembling the keratoprosthesis. This is a orokeratoprosthesis, and on the optical stem you do the 8 millimeter dissection of the donor graft, and we put the carrier graft over the optical stem. Now after that, what we do is we put the back plate of the prosthesis over the carrier graft, and we lock the whole thing with the titanium ring. Now it is very important to lock it properly and check whether it has been locked, otherwise it can cause lot of problems later on. Once this was over, we complete the trephination, host trephination. The cataract was removed. Nowadays we do keep the posterior capsule so as to keep the anterior and the posterior segments separate, and did the BBI, and later on it was sutured the way we suture the PKP. Then the panels was sutured with the 80Y krill. Unfortunately, I had got one cut at this point in time, and we did suture that cut also very properly. And while taking the bites, few bites were taken with the episcleral tissue as well. So in the end, this looks like as if the whatever we started with, it looks exactly like that at the end. For a patient, it may look just as if the surgery is not done. So after around 10 to 12 days, I made an opening over the optical center. Now I did not do the opening at the same setting because I thought that it was a full pannus. There was a lot of fibrosis. Once we dissect the pannus and again suture it, again some kind of a fibrosis is going to happen, and the whole dynamics of the optical centration would change. So we kind of let it heal for some days and then do the opening over the optical center. Now, where the cut was, I had noticed that there was a bit of a retraction of the pannus. So I did a small tenonoplasty over there and resuturing of that area. Now, this is a 2-month post-op where patient is doing pretty well. There was regular follow-up with this patient till the 2 months of time. And there's a small thinning of here, but there's no fluorescent staining, but a little bit of pooling happens. So I have to watch this particular area closely in future. So this patient gained a pretty good vision, and this patient was done during the first and second wave of the lockdown. Now it is very difficult to follow up these cases during this period, and we all know that it's the keratoprosthesis do require a lot of follow up. So this patient every 10 days sends me a video of his eye from his mobile phone, and he also sends a photo, and we do discuss about his symptoms, whether his vision is decreased subjectively or not. So this is a way we are following up right now. So this overall, at least it gives me some idea that the patient is doing well and there are no big complications. Now with the literature review, what I found out is there are few cases which are published where, like in this case, this author has done the keratoprosthesis, Boston type 1 keratoprosthesis under buccal mucosa in a case of OCP. So they did the surface MMG, and 3 months later, they did the type 1 Boston keratoprosthesis with patient's own cornea under the MMG, although they did the opening of the optical center at the same time. Dr. Basu also reported 2 cases where in one case they did type 1 keratoprosthesis under surface MMG 2 months later, and in the other case they did the modified type 1 keratoprosthesis, that is your LVP keratoprosthesis, which has a longer optical stem, so it can actually accommodate the mucous membrane graft pretty well. They did it under mucous membrane graft. Although I did not find any publication under pannus, we do know that some of our colleagues are doing this, and in fact I took the inspiration from them and did this case. So to summarize, type 1 keratoprosthesis can be done for end stage blinding corneal disease, and it is one of the procedures besides AIOC2021. But sometimes we need to do some innovations and modifications like doing K-Pro under pannus or MMG in scenarios where BCL cannot be put, or if the surface is very dry or keratinized. Thank you so much.
Thank you, Dr. This was indeed a very, very challenging scenario that you have beautifully managed, and it was a very interesting watch.
Thank you.
So thank you so much. Our next speaker for the day is Dr. Muralidhar Ramappa. Dr. Ramappa is an avid investigator. He has several publications to his record, and he has a keen interest in pediatric corneal surgeries. Dr. Muralidhar Ramappa's talk will be on the pediatric eye disorders, and your slides, Dr. Murali, and SEPA, a new technique on Peters anomaly.
Thank you, Arvind. So I'll get started with my video. I shall be presenting our work titled Selective Endothelectomy in Peters Anomaly, acronym titled SEPA, the long-term clinical outcomes in 34 eyes of 28 children with Peters Anomaly. None of the authors have any proprietary or commercial interests in any of the material discussed in this particular study. As we all know, Peters anomaly is the most common anterior segment developmental abnormality, presents with central or paracentral corneal opacification. It accounts for nearly 50% of the children born with corneal opacity. Bilaterality seen in two-thirds of the cases. Incidentally, it is also one of the most common indications for a corneal transplantation among congenital corneal opacity. This is a typical case of type 1 Peter anomaly with a posterior excavation, which is evident on an anterior segment OCT as well. In this particular instance, wider zone of cornea is involved. On UVM, you could actually see the perimeter of the corneal opacity having a synovial attachment, which is clearly evident on horizontal and vertical scans of the UVM. This is a typical case of keratoirodolenticular dysgenesis, where right and left eye of the same child, where left eye has a severe involvement with the cataract. While conservative approach applied in a milder variant of Peters anomaly, where surgical interventions are typically resolved in a severe cases of Peters anomaly, often have a abysmally poor outcome. While small subset of milder Peters anomaly tend to spontaneously recover over a time, but majority may not show a discernible clearing owing to presence of anomalous layer as shown in this particular slide. Histopathologically, the posterior defect filled with a uveal tissue and anomalous fetal membrane, as evidence in these histological slides. Perhaps this particular layer inhibits the normal endothelial migration, thereby preventing the spontaneous recovery. Based on our clinical as well as histopathological observation, we felt there is a focal area of anomalous Descemet's endothelial complex underlying the posterior defect, which perhaps serve as a contact inhibition. Once we remove those anomalous layer, the perilesional healthy endothelium tend to regenerate and fill the denuded area, lead to the resolution of the corneal edema. And also robust scar remodeling in children together with overlying well-preserved anterior stromal architecture helps in the rehabilitative journey of a child. We documented the postoperative healing response after CPA using high-resolution anterior segment OCT. At 1 month postoperative follow-up, DM is not only well opposed, the endothelium was covering the defect, which is sharply demarcated. Together, clinically, we could actually perceive stroma is much more compact and transparent postoperatively. Our intent was to determine the functional success of CPA in children with Peters anomaly. This was a single-center retrospective consecutive interventional case series. The study included 34 eyes of 28 children with visually significant Peters anomaly that had undergone a selective endothelial removal with or without additional procedure. The study was conducted at LV Prasad Eye Institute, Hyderabad, India, over a period of 8 years between 2012 and 20. Based on the location and extent of the corneal opacification, the corneal opacity can be categorized into the zone 1, which is a central island of corneal opacification within central 6 mm. Zone 2, central cornea with a peripheral cornea is involved. Zone 3A is a near total corneal opacification. Zone 3B, complete corneal opacification. This is a technique demonstrating selective endothelectomy. Step 1, severing the communication between iris and cornea. Step 2, identifying the actual defect. Third step, delicately removing the anomalous corneal endothelium without disturbing the integrity of Descemet's membrane. Step 4, checking the integrity of Descemet's membrane. There was no Descemet detachment at the end of surgery. Type 2 Peters anomaly, wherein additional lens aspiration along with sphincterotomy was considered in view of a large corneal opacity. The sequential picture collage of a milder variant of Peters anomaly, right and left eye of a same child, showing the postoperative corneal edema resolution with a scar remodeling as observed over 18 months period. In contrast to the top row, wherein had an extremely good outcome with a smaller zone of corneal involvement, the bottom two rows had a wider zone of corneal involvement that resulted in a suboptimal outcome following this intervention, which was observed over a period of 6 months' time. The sequential picture collage of severe Peter anomaly, top and bottom row showing a significant improvement in eyes with a smaller zone of corneal involvement compared to the middle two rows where corneal opacity is much larger along with a cataractous lens, had a suboptimal outcome with a secondary glaucoma. Meaning, even in a type 2 Peters abnormality, with a smaller zone of corneal involvement can help achieve a good outcome. Primarily, our cohort included a type 1 abnormality. Median age at surgery was 7.2 months, and 85% had a discernible corneal clearance. So the 97% had ambulatory vision, and BCVA significantly improved owing to the resolution of the corneal opacification. On careful evaluation for the factors responsible for a SEPA failure, we found that one is severity of the disease, the zone of involvement, and additional intervention seems to be the important risk factor for the non-resolution of the corneal edema. 85% of the mild to moderate cases had a significant corneal clearing in comparison to the severe disease. The cornea tend to clear even beyond 12 months, so perhaps this may be related to the remodeling ability of the younger children. Over the last 3 decades, the literature primarily focused on anatomical success has shown a modest outcome, and only 20 to 60% of them achieved a 2400 or a better vision at a median follow-up of 4 years. The current study, where most cases have actually showed a significant improvement, and vision is continued to improve over a period of time. Our study validates the long-term outcome of SEPA. It's a novel, less invasive surgical strategy for the treatment of Peters. In 85% of the cases, opacity is significantly cleared with a marked improvement in the visual functions. We've also demonstrated to the best of our knowledge for the first time that SEPA can be used even in cases with a severe form of keratolenticule adhesion as long as the central corneal opacity no more than 7 millimeter, or at least half of the peripheral cornea has remained clear. The findings of our study questions the prevailing paradigm whether this procedure could be offered as a preferred surgical modality in every case of Peters anomaly, or only in a select cases where corneal opacity less than 7 millimeter, irrespective of the type of Peters anomaly. The long-term results are extremely promising, can be a very effective surgical alternative to penetrating keratoplasty, and this would benefit hundreds of children with Peters anomaly related corneal blindness worldwide. Thank you for your kind attention. Thanks, Aravind.
Thank you, Dr. Murli. SEPA indeed is a very promising technique and perhaps it is going to revolutionize pediatric corneal surgery. So thank you for sharing this very ingenious topic with us.
A couple of questions, Arvind. Can I just ask Murli? Do we have time?
Okay, Dr. Anand, we were actually planning to take the session questions at the end, but maybe a quick one before we go to the next.
Just a query, Murli. Nice, very nice. Two questions. One is with respect to surgical technique. When you're actually doing the aspiration, you're actually just sucking out with an IA. Am I correct?
You're right. Right.
So you're not using like a reverse Sinski to kind of take out any.
No, I'm not. I'm not doing a desmetorexis. No.
Okay. That is one. The second was when you're looking at, when you said grade 2 and above, like Peters grade 2 and above, you probably, all those patients would definitely require lens involvement. Yes. So those, any specific reason why those patients did not actually do well? Because you're treating at least one additional cause of visual performance being poor.
Yeah, extremely good question. If the area of corneal involvement more than 7 millimeter, then they don't do that well. So you may have to combine optical iridectomy. So I have title acronym like a SEPA, SEPO, SEPAL. So wherein you have an additional steps like lens aspiration or optical iridectomy, right? So yeah, in terms of comparing to the those which had a less than 7 millimeter, they had extremely good vision. Some of the children have improved to 20/40 vision. Whereas a type 2 with larger than 7 millimeter, they have a pretty decent ambulatory vision, 2400 to 2800. So that was a meaning, the comparison between the type 1 and type 2. Yeah. Otherwise, if you look at the penetrating keratoplasty outcome in a long run, so we had only 22% success at the end of 2 years. And also, if you look in terms of functional success, they're extremely poor. in a long run, considering the longevity of the child. So I think, this particular innovation actually works very well.
Dr. Manoranjan, please share your slides while the discussion is also going on. Yeah. So thank you, Dr. Anand, for this very pertinent questions and also the very interesting developments that's happening in the pediatric corneal surgery. So thanks, Dr. Murli, once again. And our pleasure to have Dr. Manoranjan Das from Arvind Eye Hospital, Madurai. Dr. Das is going to discuss on keratoplasty in difficult situation, a avid academician with an extensive publication track record. Over to you, Dr. Das, for your talk.
Good morning, one and all. And at the outset, I would like to thank the AIOS and the Dr. Somsila for giving me this opportunity. So today's topic given to me is the tips and tricks for keratoplasty in difficult situation. And actually, all of us will love to do the advanced surgeries like lamellar, whether anterior or posterior. But still, I feel the keratoplasty in difficult situation remains a challenge for all of us, irrespective of our experience. And it takes some guts to finish the surgery in a proper way. Next. So the common difficult situation can be keratoplasty in glaucomatous eye. And again, then keratoplasty, we repeat keratoplasty with IOL removal and lens removal and IOL implantation. Then periodic keratoplasties, then penetrating keratoplasty in a complex herpes or corneal opacities, and then large diameter corneal grafts like keratoglobus or a rupture pellucid marginal degeneration, and keratoplasty in aphakias. So all these difficult situations will have a common difficult problem. So common difficult problem like inadequate achalasia, positive vitreous pressure, lens expulsion, bleeding from the vascularized cornea, definition technique difficulties, definition in perforated corneas, and endothelial loss during the procedure, and a poor wound apposition, flat graft or IOL power calculation in scarred corneas, and large graft management. So coming to one by one situation, to have this to get rid of this inadequate achalasia or positive vitreous pressure or lens expulsion during the surgery, we should have good anesthesia with a perivalvular block and hyaluronidase with good facial massage and after the block, and control of systemic infection like hypertension and asthma, and secondary glaucoma should be controlled with IV mannitol. Patient head of position, proper speculum selection, canthectomy, and use of flaring rig wherever needed, and vitreous tap whenever needed when the glove is hard, and the use of price graft over host technique will be necessary to tide over these situations. Bleeding from vascularized corneas can be pre-op handled by using brimonidine or phenylephrine drops, or controlling the ocular inflammations. Wet field culture can be done, and subconjunctival or perilimbar Avastins are given by some surgeons during or after or before surgery. Definition techniques difficulties can be is a big challenge during the surgery. We need to get a good optical center marking, and for that we should first remove the bullous keratopathy from the cornea, and then use the radial marker. Use of vacuum trephine is advisable in all these cases. Microscope illumination should be perpendicular to the iris plane so as to have a good centration. Glove, if at all it is decentered, can be centered with forceps, and after trephination of 3/4 depth, you should have a slow decompression. So trephination in a perforated cornea is more important. So we should only go for a facial block and then mark the cornea and go for the manual excision. And the endothelial loss can be tackled with proper tissue handling during surgery and use of viscoelastics. So poor wound apposition and flat graft can be managed by oversizing the graft by 0.5 to 0.75 size and reassessment of the graft during intra-op, and then having good suture bite and with equidistant length. So IOL power in a scarred cornea is a challenge. So we will prefer to have a IOL power calculation only after taking axial length for A scan or B scan, and then taking the keratometry from other normal eye. Or you can use the other eye normal eye keratometry and axial length and put the IOL power to get the approximate power. Large graft usually is needed for keratoglobus and advanced keratoconus or post-vitrectomy eyes. Use of flaring a ring and use of 1 millimeter larger graft along with more than 16 suture will tackle this situation. Overall, we have to give systemic immunosuppressive for all these cases because of high-risk graft. So the price over graft hold technique, which I'm going to demonstrate today, will tide over the lot of tension during surgery, how much experience you have got. So this is a technique which is described by Price, in which he has refined the host cornea and sutured in the same way first, and then after cutting the 3 to 4 o'clock host cornea, he sutured back the whole cornea, and then with the non-cardinal sutures being anchoring sutures, he has used that normal graft over it. And in between he used the endothelial cushion. So I'll show you the modification which I have done in this video. And this is a case which was a bilateral macular dystrophy, corneal dystrophy, and left eye presented to us with a graft failed graft with secondary glaucoma. And this is how we managed to do the case. You can see after the proper block, so I have modified this technique to take an anterior 80%, 70% of stroma debulking. After the debulking, reassessment of the graft size is done, and then after slow entry, I have cut the 3 to 4 clock hours of cornea, residual cornea, and I have put the suturing in the non-cardinal side. You can see the severe positive pressure and iris popping out. So after putting this non-cardinal sutures, and then you put a viscoat over the cornea, and then you start using the 4 suturing. You can put a loose sutures or a little bit adjustable sutures. Once these 4 sutures are intact, then you cut all the basic non-cardinal sutures from all sides, and then remove the residual stromal tissue. And then you can tighten the 4 sutures, usually adjustable sutures, and then you finish the surgery. So this is the sequence of surgery for that case. And next is the another case which has got the fungal keratitis, failed TPK, and it came with the desmontocele. We have also done the same sequence of surgery, but here we have done a cataract surgery along with it. So you can see the sutures are still intact. So I have cut the few sutures here, 2 sutures, anchoring sutures, and remove the lens, cataractous lens, then put the IOL and put the suture back with the residual stroma, and then completed the surgery with the graft over technique. So take homes is in the preoperative workup is needed to get a good anesthesia. In spite of good maintenance of the IOP, you still may have to be doing very fast suturing, and overall the graft sizing has to be a little bit more, about 0.5 to 0.75 millimeter, and then use of liberal viscoelastics to take over the endothelial or tide over the endothelial damage, which is expected a little bit more here. So thank you for your kind attentions. My acknowledgement to Dr. Vishnu and Naveen and on my audiovisual system for helping me out. So thank you so much, Arvind, for listening.
Thank you.
And thank you all
Dr.
the panelists.
Das. It was a pleasure hearing you and having you on this forum. I am going to take up the next talk for the session, and I shall be discussing on the renewed interest of glycerol preserved donor corneas for penetrating keratoplasty in emergency situations. So I hope my slides are visible.
Yes, yes, yes.
Okay, great. Thank you. Thank you. So, so we have no disclosures. The glycerol preservation of corneal tissue is has been in vogue since half a century, almost from the 1955-60s onwards. But it has always fallen aside because the process of glycerol preservation has rendered the corneal tissue non-viable. But the tissues can be stored indefinitely. There was a renewed interest in glycerol corneal preservation in the COVID era. This is because world over eye banking systems were collapsing in the wake of the rapid rise of the pandemic, the surge of cases, and thereby the consequence on decrease of corneal retrieval because of COVID. So when we reviewed the existing literature, we found that glycerol corneal preservation is a very easy to perform procedure. It can be used by any eye bank and it doesn't require a lot of equipment, and the storage is fairly simple from room temperature to minus 80 degrees almost. And these provide a source of corneas for emergency and tectonic purposes, such as tectonic or therapeutic penetrating keratoplasty. The drawbacks of this technique are that the corneas tend to be acellular and therefore they lose their clarity over a period of time. But the corneas that are preserved in glycerol tend to have excellent clarity during the process of preservation and they gradually become opaque. So if we see this IOVS paper from 2012, the top two pictures show corneas that have been preserved in glycerol at minus 20 and minus 78 degrees compared to those in the bottom where they have been preserved with silica gels or without silica gels at room temperature. So initially they are clear to start with, and they are typically preserved in vials of 20 ml of sterile glycerol, which is 99% pure, and they need to be thawed by thoroughly washing with BSS and then allowing it to hydrate over a period of 10 minutes before preparing them for transplantation. This was a clinical case of a corneal melt which very rapidly progressed to a 6 millimeter central corneal perforation. A glycerol cornea was used because this case was performed during the pandemic and fresh tissue was not available. A freehand dissection was performed after marking the cornea, and once the trephination is done, the glycerol corneal tissue which has been thawed was used. So as you can see at the beginning of the surgery, glycerol corneal tissues tend to be fairly clear and it allows somewhat good visualization of the anterior segment. However, the tissue tends to swell up during the surgery and it becomes opaque, and suturing also is a bit difficult because these tissues are stiff and they may not be very pliable. So this was the surgery that was being done, and a flanger ring was used because it was a large corneal perforation, and the procedure was completed with 16 interrupted sutures. The postoperative outcome was uneventful, and at 4 weeks, the graft had taken up well, it has started to fail, and there is also a good epithelialization, and the posterior segment was normal with retina on. This was another case where, again, similarly, glycerol corneal tissues were used, donors were used, and it resolved uneventfully except for intumescent cataract, which necessitated extracapsular cataract extraction. And at 4 weeks, the graft was beginning to fail, but the posterior segment was essentially normal. So these cases could be taken up for subsequent management in terms of the optical keratoplasty once the graft has taken up. So the eye could be salvaged in such cases. This was again a similar case of extensive fungal keratitis necessitating treatment with glycerol preserved corneas. There is also a drawback of these tissues. The epithelialization is extremely slow, and in this case, typically, this is the epithelial defect at 1 week, and again, it at 2 weeks, and almost at 5 weeks, the epithelial defect still persists. The epithelialization is extremely delayed, and often these persistent epithelial defects, unless addressed by a concomitant tarsography, might lead to melt in the graft. When we compared the outcomes of glycerol preserved corneal tissue in our study, which is currently under review, with a paper that has also been published in IJO by Gupta et al., we found that the very common post-operative or perioperative complications are either a recurrence in the graft, delayed epithelialization, and glaucoma. All in all, there are certain interesting surgical tips that we learned, picked up along the way, are that it needs adequate hydration and thawing before using a glycerol preserved cornea. A sharp trephination is desirable. The tissue tends to opacify as the surgery progresses, and suturing is difficult, and sometimes that's the reason why the surgery can be a bit prolonged. Tarsography certainly will be advisable because the tissues have a very slow rate of epithelialization. Apart from that, these tissues do very well tectonically, and they can also be taken up for lamellar transplants. Thank you very much for a patient hearing, and I would like to take this opportunity to thank the scientific committee and Dr. Somshila Murthy for this excellent session on corneal tips and tricks. Thank you very much.
Really nice, Arvind. I enjoyed the presentation.
Thank you, Dr. Anand. And our next speaker is Dr. Anand Parthasarthi, a very senior surgeon, and he rarely needs an introduction. I would like to invite you for your talk on the intraoperative OCT. Over to you, Dr. Anand.
Enjoying this session a lot. My slides are visible.
Your slides,
yeah, make it full screen, sir.
Yeah.
So I've been asked to speak on See Closer, Go Deeper. Just a couple of hacks of intraoperative OCT for corneal surgery, and it's been a very good additional modality for intraoperative visualization, and it really helps across almost all endothelial keratoplasty, DMEC, Dissect, SLET, DM detachments, and of course DAL dissections. And I'll just touch upon some of them as we go along. I think what is probably the best and most important thing is that you get real-time images. It is continuous, and the present OCT, the Zeiss which I have experience with, has both horizontal, vertical, and of course a raster pattern, which actually helps multiple times. So you don't really have to move the microscope multiple areas. Now, this is a hack which I realized when we want to really use the cornea, and this was the OT where I had two patients, one for DALC, one for ultra-thin Dissect, and I had to make sure that I did the dissection perfectly so we have enough cornea for the keratoconus. Now, this is a 350 micron blade. So I thought, you know, peripheral thickness being 600, I went a couple of times. I thought I'll be about 400, and I started the dissection. And you can make out the depth. Sometimes what you get on the blade is sometimes not accurate. We are hardly 50%, not even 50% of it. And once I started the dissection, I saw it on the intraoperative OCT. I realized that our dissection was less than 50%. So you have to be careful with a lot of these guarded depth knives. You may not really get them what they say. So also important to note that in edematous corneas, you probably need to overcorrect by about at least 10 to 15% beyond the depth that you intend to go. And you can make out the dissection. Now it's hardly about 50%. So I decided to go back again, re-deepen it with the same knife, and then attempted to go. I thought now I'm probably about 80%. So that is the perception as a surgeon. But when I restarted the dissection, saw it on the microscope, I realized I was about 60%. You can make out on the intraoperative OCT, there are two cuts. The first is about 50%, the second is about maybe 60, 65%. And then we decided to go deeper because I need at least about 80%, 90% of the anterior stroma for a keratoconus patient. So we finally went deeper again, and then I started the dissection. Now you can make out that you got three levels of dissection: the first, second, and the third. Third is the longer one, if you can make out the OCT. So this is what I wanted. And if you are very careful, and this I feel is the real advantage, that you can do a very considered and conscious dissection. And once you go across, you can make out that the depth I'm actually now getting almost at about 80%. And remember, these corneas post-op will thin. So you have about 80% of anterior stroma for the keratoconus, and you have 20% of the posterior stroma for the ultra-thin dissect. And if you're very careful, even people who don't have a proper automated keratome, you can actually go ahead and get a very, very clean, uniform dissection across all planes. And you can, as you take this using multiple dissectors across, you can make out a very, very good dissection plane across all levels. So this really helps if you're doing it consciously across even the other side. Now I'm on the other part of the cornea. You can make out the dissection is actually quite good. See, the depth is very good. I'm actually quite happy. So we actually went ahead with what we planned, and we didn't have a surprise when we finally finished the dissection. You can make out, just to show the depth of the dissection, actually quite good. The second is this patient in which we did a femtodalk. Now this is the recipient, and just to show that the step ladder pattern, because in femtodalk, this is femto-assisted dalk, wherein you do the anterior, this is a keratoconus, so you can actually make out the very good step pattern. And this we oversized about 0.2 for patients with keratoconus, and this is the step pattern, very, very nice. Because the tricky part in femtosecond, remember, is sometimes you don't actually get the bubble as you would really want. So you peel off this. We decided to do a manual dissection because we were not getting a separation of the posterior stroma. I tried an air emphysema, I was not getting it. Then we decided to basically go ahead with a dissection, a manual dissection. You can make out that I've not actually got a complete dissection, maybe about 80–90%. So I decided that I don't want to take a chance with just air bubble injection. We do a manual dissection, and it is multiple layers, very, very gradually. As you go deeper, you can actually make out that if you are conscious about what you want to do and what you aim to do, you can get these corneas to almost about 90%. This is the end of dissection. You can see the lump of the stroma, and we are at about 80%, which I feel in a patient with keratoconus will get as good results as getting a big bubble dalk, because we've done studies on that. The manual technique actually works quite well. This is the end of dissection. You can make out we are almost about in the central visual part, which is important. We are almost about 85–90%. And the peripheral dissection is done. This is for the donor. Also, just to make sure you got the step correct, this is important before you remove it out of the artificial anterior chamber, and then basically place it. You can put trypan blue to remove the descendants and then place it right. The fit is actually quite good, and it's almost like a lock and key fit. And these patients actually do quite well post-op. You just need maybe about 8 sutures to finish these surgeries. This is a video from Dr. Namrata, just to show that this works quite well for DMEC as well, especially for removal of the donor. And once you inject it, and probably in DMEC, the application of the intraoperative OCT has been quite significant, just to show the scrolls which show the orientation of the corneas. Now, this is also important, especially in DMEC assisted for dissect, as well, to make sure that you remove the water clefts across the position of once you insert the, because we feel that on anterior chamber, when you actually visualize it, and if you have slightly bad corneas where you do not have good visualization, you can make out these water clefts which need to be eliminated. So I usually do paracentesis, basically full thickness corneal incisions on the recipient stroma, and you can actually, even when you're injecting air, you can see that the graft actually moves. So you got to make sure that all these water clefts are clear on table. So you might take 5–10 minutes extra. In desmetopexy, important, especially post-cataract DM detachments, you can still get peripheral detachments. These need to be removed. A hack which I learned from Dr. Namra is to put a bit of Helon or use the cotton bud to make sure when you remove the needle, the AC doesn't shallow, because that itself can cause a detachment again. In SLET, important to know the depth of this dissection, especially in terms of whether the stroma is actually involved quite deeply or not. In type 1 bubble dalk, as you remove the bubble, you will see that the descendants actually gradually comes up. This is a very nice indication that you've got the big bubble if you're not using the small bubble technique. This is just, I think big bubble I've already mentioned. And in interest of time, I will just conclude by saying that the intraoperative OCT is a very useful addition. It is very effective in tricky situation, acts like a third eye. It is an important part in the armamentarium of corneal surgeons, and usually helps to improve optimal outcomes post-surgery. Thank you so much for your attention. Thanks, Arvind, and thanks, Sheila.
Thank you, Dr. Anand. Excellent summarization. And I would like to invite some more discussion on DALK, Dr. Jayanshu Sengupta on DALK tips, tricks, and DALK despite a failed bubble. Over to you, Dr. Jayanshu.
Sorry to interrupt, but doctors, let's just move a bit quickly because 10:55 this session has to end.
Arvind, can you just start Pravin's talk? I will just share in a while.
Okay. So our pleasure to have Dr. Praveen Subudhi. Praveen is an excellent upcoming surgeon. He has a passion for corneal surgery, a friend, and also someone whom we collaborate regularly with. Praveen, over to you for DSEC in challenging scenarios, tips and tricks.
Thank you, Arvind, for this kind introduction. I would like to thank, first of all, to Dr. Somasila Murthy, who was my mentor for my learning for DSEC in LVP. So as we all know that PKs are still the most common forms of transplantation being underwent all over the world. Still 80% of the cases, 75 to 80% of the cases undergo full thickness keratoplasty. Lamellar holds less. In institutes they undergo, but in tier 2, tier 3 cities, still the PK remains the most common form of transplantation for corneal diseases across all corneal diseases. And in these cases, and during, as we are reeling with the pandemic, the patients are having poor compliance and no timely follow-up, and these cases have a very high risk of rejection and failure. If you have a proper medical compliance and a timely follow-up, then the graft longevity will be good. But due to the pandemic, the patients are not able to come, patients doesn't have an access to medications, and these eventually are causing rejections and failures. So it is very important and very critical. If you have a telephonic conversation with your patients, you can tell the patients to take the medicines properly, timely put the steroids. If they don't have, and definitely they have to have a teleconsultation. Now, as the pandemic is coming down, the patients are able to come, but still we had the golden time last 6 months, 7 months, where there was complete lockdown. During this period, the patients were not able to come to the hospital, eventually causing rejection and failure. So this is a patient, a 68-year-old male who came to me 4 years back actually for a corneal ulcer. The patient had a perforation, and then I had to treat it conservatively, and it eventually went for adherent leukoma. Patient underwent keratoplasty 4 years back, and patient was doing well. And then after 6 months to 8 months, the same patient underwent trabeculectomy and cataract surgery because of the glaucoma and the cataract. Patient had good vision for 2 years, following which he had a failure. And patient was under anti-glaucoma drugs, and the other eye was patient's eye was gone. But in the first pandemic, the patient did not come, and ultimately he did not use the drugs. It led to the rejection and failure. So here what I had to do, there are certain tricks, I think basic for all the institutional people, but for the practitioners, it's a very good things I can share here. It's better in cases of failed grafts. When I go for a DSEC, I always go for a 150 micron because that helps in easier manipulation in the intracameral space. And these are the Bhaskar instruments from the Joja Surgicals, which is easily available. And once you reach the half of the cornea, you can use the blunt dissector to complete the process. You need to ensure that you reach the limbus 360 degree. So that when you separate the lamella, it should not be attached. And while removing, you need to be careful. Here, when you are removing, you need to be careful because you may touch the endothelium to the artificial chamber. And you need to put little bit of viscoelastic so that you can protect the central endothelium nicely. And while refining, you need to be very careful. If you are eccentric, you may land up in trouble. The mark is important for the initial cases. It's very important. If you don't have the S mark, you can use a Sinskey hook to do the mark. You need to be careful while removing. And now, as you can see here, the visibility is poor. You have to peel off the epithelium as much as possible to have some amount of vision, amount of vision to the intracameral space. And for the tunnel, it's very important here. You need to have a for the tunnel, you need to have here, the important trick is you need to have a small tunnel, and you have to just break the adhesions with the help of saline. I usually prefer a sheets glide because that is helpful. That works for me nicely. You put a cohesive viscoelastic. When you push the lenticule, I usually follow the push technique rather than the pull technique. In pushing, you have to go in a single go. And you need to be careful while removing the glide because the lenticule may come out. One stay suture you can put here because that prevents the lenticule to come out. You may not tie it. If you want to manipulate from the main wound, you can manipulate. That's very important because you put a stay suture. If you don't put a stay suture, it may come out. And then you can just put the air bubble and 2 sutures you can place it. And this is the post-op picture. The patient is having a functionally good vision up to 6/24. This is another case where patient had a complete ocular surface failure. The same thing had done. And the patient is doing fine for last 2 years with almost 6/24. The patient improved from hand movements to 6/24. So non-dissect is a very excellent technique and it has been proved in multiple literatures. And you need not go for a decimate stripping in these cases because you may end up in graft host dehiscence. So for the shortage of the time for next presentation, I will end this presentation. Thank you very much for the kind attention.
Thank you, Praveen. Excellent innovations and very difficult surgeries to perform always. So our next talk will be by Dr. Jayanshu Sengupta on dark despite a failed bubble. Over to you, Jayanshu.
Recording in progress.
Yeah, am I audible now?
You are audible and slides are visible.
So we are all aware of the big bubble technique. Because of shortage of time, we will just not move. And many a times we do go to the manual dissection. And but however, as we all are aware that big bubble is not always possible because of inadvertent reasons like where we have a dense scar or inaccurate positioning of the needle and things like that. So we go for a lamellar dissection and then we are sometimes lucky we can get a very good bubble. But in majority of the situations, we may really land up in big trouble and not achieve a manual dissection completely. So manual dissection is fraught with problems in the form of microperforations or macroperforations make our life difficult. Now in this situation, we have a perforation below the stroma while we were dissecting. So there we are putting air into the anterior chamber, giving a layer of fibrin glue on top of it. Fibrin glue adds bulk and this helps us to carry on the dissection further, and we can really go up to the clearing of the Deschmet or as big as possible in a better way. So, but what I wanted to highlight upon is, just a second. What I wanted to highlight upon is another thing. Just a second, I just missed it. Somehow I deleted it. Yeah, this is what is it visible?
Yes, it is visible.
Yeah. So this is what I am nowadays performing. I don't have an access to an intra OCT, though we are in the process of negotiating into one. But till that time, once we have the refine or the mark, we put in the air bubble, we do not always get a big bubble to start off. So in that situation, we use we do not get a big bubble, and we have the lamellar dissection with the blade, and after that we fail with the visco dissection of the plane. At this point of time, it is better to shift to the the vexel sponge dissection, because this sponge is stiff at the tip. It has a perfect dissecting edge, and this gives us this helps us to go very close to the dashment, if not reach the dashment in many situations. And at the same time, it helps us to maintain the visibility during the procedure and gives us a very decent surgical outcome, irrespective of the situation that we are in. So this was a prime video which I wanted to show. Rest are all other bits. So I think we are lacking in time. I will skip. I will stop over here. Thank you, Arvind, and thank you, Dr. Somshila.
Thank you, Janshuda. I think very crisp and very interesting. Certainly, we would love to try this technique. So thank you all. This was a fantastic session. Lovely to have all of you on a Sunday morning. Look forward to being in touch with all of you. And thanks, Ekta, for the wonderful support. Thanks, Dr. Somshila, Dr. Rishi, and Dr. Bhaskar Roy Choudhary for the support. We hand over to the next group, and thank you all for joining in.
My pleasure, sir. If you don't mind, let's take one last screenshot with the maximum.
Yes, I request all to kindly switch on your cameras for a moment.
Okay, looks awesome. Just give me 1 second now. Smile, guys. Done. Thank you.